Good morning, afternoon, and evening. My name is Lisa Moicambo, and I am a Senior Program Officer at Johns Hopkins Center for Communication Programs. I will be presenting on elevating stakeholder voices, key factors to facilitate locally driven family planning programs. Before I jump in, I'd like to share with you the learning objectives for the session, which are to familiarize yourself with the most significant change technique as a technique to complement project monitoring and understand the key factors that facilitate scale up of evidence-based family planning and reproductive health interventions from a secondary analysis of 96 MSC stories collected as part of the Challenge Initiative, a Bill and Melinda Gates Foundation funded project. First, let me give you some background on the field of scale. Scale refers to the deliberate efforts to increase the impact of successfully tested health innovations so as to benefit more people and to foster policy and program development on a sustainable basis. Scaling up public health interventions implies that interventions will be transformed into mainstream practice. That is, that they will be integrated into the existing health system. This transformation is influenced by characteristics of the innovation, the context, and the user organization. Despite the development of effective innovative products, practices, and programs, their impact often remains limited and the outcomes are generally not sustainable due to scale-up challenges. As a result, our study looked to answer the question, what influences sustainable scale-up? Specifically from the point of view of local government and public health sector stakeholders who are implementing and scaling up evidence-based family planning and adolescent and youth sexual and reproductive health interventions. And secondarily, how do the findings from this analysis align with TCI's guiding principles? I will share more on TCI shortly. TCI builds on the learnings and evidence-based approaches from the former Urban Reproductive Health Initiative, which included 4 rigorously evaluated projects implemented in Nigeria, Senegal, Uttar Pradesh, India, and Kenya between 2010 and 2015. The URIs, as they were known, were a proof of concept, while TCI was designed from the outset as a proof of scale, with an aim to support city governments to sustainably scale up the evidence-based approaches that were identified under the URIs. So TCI's guiding principles for scaling up include being demand-driven. Local governments self-select and bring their own resources, financial and human, to addressing their family planning issues. It involves local ownership and system readiness. So local governments must be ready, willing, and able to address their issues by leading implementation of the evidence-based interventions. Right-fitting interventions refers to TCI's work with local governments to ensure evidence-based interventions are adapted and responsive to the particular nuances of local conditions and context. Coaching support. TCI provides support to local governments to design, manage, and implement the programs themselves. TCI leverages and activates existing structures and systems and looks to get the evidence-based interventions incorporated within existing government-led and owned strategies and plans so that there's funding available and there's an avoidance of duplication, waste, and missed opportunities. And the use of near to real-time data is critical in informing adaptive management and ensuring regular problem solving and evidence-based or informed decision-making. So TCI is led by the Bill and Melinda Gates Institute for Population and Reproductive Health at Johns Hopkins Bloomberg School of Public Health. TCI works through 5 regional partners or accelerator hubs: Johns Hopkins Center for Communication Programs, CCP, in Nigeria, Population Service International, PSI, in India, JPIGO in East Africa, IntraHealth International in Francophone West Africa, and the Zellweg Family Foundation in the Philippines. TCI does not implement itself. It allows city governments to really lead the effort, with TCI building and strengthening city government's capacity to do so. So since launching in 2016, TCI has scaled to 104 cities. This includes 12 states in Nigeria across 11 countries. It covers a population of approximately 110 million. So far, local governments have committed 137 million to implement TCI, and donors have invested 32.6 million in TCI outside of the Bill and Melinda Gates Foundation funding. Here's just a selection of some of those evidence-based interventions by hubs to give you a sense of what are the interventions that are being implemented by city governments and scaled. Philippines isn't listed here on the slide because it's just begun implementation as of March of 2021. So TCI employs a mixed methods approach using both qualitative and quantitative data to capture, analyze, and share learnings among TCI stakeholders at different levels. So there's the city level, the hub level, and the global level. Monitoring tools such as project records, PMA Agile, TCI's local tracking surveys, and the Health Management Information System, or HMIS, of the local countries will answer questions related to, did change occur? Are we seeing increases or decreases in certain of our indicators? While the most significant change technique really answers the question, how did this change occur and why is it important? TCI believes that changes in knowledge and attitudes will impact changes in practice. These are the necessary precursors to impacting horizontal scale-up, which is service expansion or replication, and vertical scale-up, which focuses on institutionalization, like changes to policies, budgets, training, supervision, procurement, and reporting systems, to name a few. Through MSC, TCI measures the elements of sustainable scale-up by asking geographies about changes in these domains. Information about how and why things are changing or not changing help us to better understand the situation, the need, and the approach we can take to adapt and innovate to support sustainable scale-up. So what is MSC? It is a participatory monitoring and evaluation technique. It is participatory because many stakeholders are involved in the process. It is a form of monitoring because the stories are intended to be collected at regular intervals throughout the project lifecycle in order to track changes as they are emerging, rather than waiting until the very end of the project when it may be too late to make improvements. MSC contributes to evaluation because it provides data on impact and outcomes, which can be used to help assess the performance of an initiative as a whole. We chose the MSC approach because the format allows staff to identify unexpected changes as a result of the program. This is especially important when there are so many stakeholders involved, from advocacy and design to implementation. Stories about change and not just activities that occur help us identify the most important values in the project. Because it's participatory and easy to understand, we can collect a rich picture of what is happening on the ground. There's no need to explain what an indicator is. Everyone can tell a story about events they think are important. Lastly, but not at all least, is that analyzing change stories can help build capacity among staff and in the geographies on data analysis for program management. So at its very essence, the most significant change technique can be boiled down into 4 basic steps. Collecting stories about significant changes experienced by people as a result of the project or initiative. People describe what happened, then they explain why it was significant to them. The second part is key to uncovering why changes are important and how it affects their work, their lives, their communities. We aren't interested in testimonials about things people have enjoyed, but rather stories about change and why those changes are significant. The method also helps program staff explore unexpected changes or challenges that may have happened as a result of the project. So then the second step is really the selection of the most significant stories. And this involves a group of people at different levels of the organization or initiative discussing the stories and selecting those that they think are most significant. This is a key part of the process because it encourages stakeholders to have deep dialogue and it surfaces values. This adds a level of rigor to the qualitative data and also provides a validation process. With the third step, the feeding back of the selected stories, the goal is to promote ongoing dialogue and learning so that the selected stories are fed back to the storytellers as well as all project stakeholders. And then finally, the learning collected from the MSC stories should be used to improve the program. Additional optional steps to the MSC technique include meta-monitoring and secondary analysis. Meta-monitoring really focuses on attributes of the story, such as who was the interviewer, in which city, country was the story collected, who was the storyteller or interviewee, their job title, sex, and whether or not the story was selected and why. Meta-monitoring allows one to see whether or not certain stakeholder groups and voices are missing from the stories collected. After examining these basic attributes, our research team conducted a secondary analysis to further examine which themes were most frequently reported as most significant in implementing and scaling up the evidence-based interventions. The main reason for TCI's MSC data collection is to really inform implementation and make adaptations accordingly. While in the study, we looked at the MSC data from across the 4 regions to identify key factors that facilitate implementation and scale from the perspective of stakeholders. The stakeholders interviewed represent those adapting and implementing evidence-based family planning interventions and those responsible for the oversight and financing of family planning programs at the city, municipality, county, or state level, depending on the location's particularities. Some family planning clients and TCI project staff were also interviewed. As you can see, of the 96 stories collected, almost half of the stories come from TCI's primary target audience, local government stakeholders and service providers, while the rest represent others of interest and involvement in the TCI program. The distribution by sex of the interviewees reveal that more females were interviewed, but this might be reflected by the primary target audience of TCI being family planning service providers. This graph shows the geographic distribution of the MSC stories, and the specific time frame for data collection differed by region, varying from only 6 months in Francophone West Africa to 15 months in India and Nigeria, based on when the training on the MSC technique occurred in country. This explains the difference in the geographic distribution of stories. But in general, the timing of these stories correspond to about the 2nd year of implementation of TCI-supported evidence-based interventions. The final analysis included 55 unique codes. The research team analyzed the codes and considered how they could be combined into overarching themes using the 6 guiding principles of TCI described earlier as a general analytical framework. Some codes formed main themes such as strengthening capacity and improving data use, while others were deemed irrelevant to the purpose of the study, such as background-related codes, and were excluded from further analysis. The authors iteratively refined the themes to ensure the data within each theme was meaningful and coherent while simultaneously ensuring clear and distinct differences between the themes, ultimately grouping the codes related to the aims of the study into 5 themes: strengthening local capacity, shifting mindsets towards local ownership, improving government health systems, improving data demand and use, and enhancing coordination of partners. Here are some quotes that highlight the different themes. In terms of the theme related to strengthening local capacity, we heard from a government official in Dar es Salaam, Tanzania. We, the government staff, are now involved in planning, budgeting, monitoring, documenting, and evaluation. Right now, planning is done at both facility and municipal levels. Through TCI, there are so many improvements, and our activity and budget plans are smart. Most of the challenges we used to face have been minimized. The local government knows the community's needs, and we now have a sense of ownership, and we aim at sustaining it. Likewise, we heard from a government official in Saharanpur, Uttar Pradesh, India. Family planning was the last thing on anyone's mind at our UPHC, our Urban Primary Health Center. However, after observing and participating in the special Fixed Day Service Drive, which is a TCI evidence-based best practice, in 2018, facilitated by TCI, I saw people coming in for family planning services. From that day onwards, we regularly conducted FDS. And from August 2018 onwards, we are conducting FDS without the support of the TCI team. In terms of improving government health systems, we also heard from a government official in Indore, Madhya Pradesh, India. Defining the catchment area of each facility with ward and slum population details is helping all government health programs, including immunizations, FP, and MNH. This has resulted in improving FP and MNH service uptake and better reporting from each facility on all HMIS indicators, including FP and MNH indicators. Overall, the mapping and listing process, which is another TCI evidence-based approach, has resulted in the strengthening of the urban health system. So what do we learn from this analysis and the 5 themes that emerged from it? Well, the 5 themes largely align with the 6 guiding principles of TCI. However, demand-driven and right-fitting principles did not come out as frequently as the other principles in the MSC stories. This may be for 2 reasons. First, both of these principles, being demand-driven and right-fitting, are built into the process of engagement with TCI, in which local governments decide whether to complete an expression of interest to join the TCI partnership and select which evidence-based interventions meet the needs of their specific context. As a result, the interviewees may not view these aspects of the model as part of the implementation approach, but pre-implementation processes. Second, a number of the principles are interrelated. For example, demand-driven and local ownership go hand in hand. However, interviewees reported more frequently about the significance of the mindset shifts that they experienced toward local ownership in leading and managing their family planning programs and implementing the evidence-based interventions than the demand-driven aspect of the model, which really refers to their committed financial resources to implementation. The analysis also revealed that the stakeholders view coaching local governments to align and adapt evidence-based interventions within existing government systems and structures as a significant factor, which is related to the process of right-fitting or adaptation, but didn't mention right-fitting and adaptation specifically. One important aspect that also emerged in our analysis that could be emphasized more in TCI's guiding principles is community ownership in addition to local government ownership. Community ownership and mobilization have been identified in a recent systematic review as crucial factors of intervention sustainability, and therefore should be elevated at a similar level to the importance of local government ownership. We believe the cornerstone of successful implementation and scale efforts is coaching of the local health system actors to strengthen their capacity to design, implement, manage, and continually monitor and adapt their own health programs to changing conditions. Shifting mindsets and fostering local ownership start with building and cultivating leadership, as noted in the literature by Bronson and co-authors in 2018. So initially, TCI looked to provide coaching support and capacity strengthening support as it related specifically to the technical implementation of these evidence-based family planning and reproductive health interventions. However, very quickly, TCI learned that it really needed to also include coaching support around general leadership and project management or program management skills, coordination, planning, budgeting, and use of data to inform decisions. So this move to be more holistic in its coaching support has been hugely successful in responding to the demands and needs of the stakeholders, as also evidenced by the stakeholders reporting coaching and capacity strengthening as very key elements and factors for successful implementation and scale up. However, we also know that more needs to be investigated relating to the TCI's coaching approach. And a study is currently underway to document the how of the coaching approach and to really assess the specific outcomes that are associated with coaching. For more information related to this study and our findings, you can check out our article, which is forthcoming in the Globalization in Health Journal, and the preprint is already available online. As well as, please feel free to reach out to me, Lisa Moicambo at jhu.edu for any questions. I look forward to the live session of questions that we have shortly here as well.